All right.
All right, your
Well,
mic is on, so you're good.
good morning, good afternoon, and good evening to everybody who's listening and actually tuning in. Thank you guys for being here. We are going to approach this particular lecture in a different approach. I am Dr. El Sayed. I go by Dr. Jamal because it's easier and easier to approach and connect with people that way. I'm a third year resident at Freeman West ER, and we are emergency doctors. So the pleasure to identify and talk about shock has been really a great honor for me and for you guys. The idea here is that I had like different definitions of shocks in the first year. If you were able to hear my lecture that time, and then the second time I did approach to shock, and it was like a how to approach it. And then this time I wanted to have a different approach to it, which was identification. So it's identifying shock and how you can have that early identification. And I think the reason why we're able to save lives is because of you guys and how you have that early identification of shocks in general. So, what is shock? And what's the deal with shocks? And how can we actually get it? And the idea here is that, yes, exactly, you got to high five yourself because you are actually doing a lot behind the scenes that we're not able to approach and appreciate until we actually see you guys coming and did all your stabilizations that is required from you. So let's get to it. So I like to approach it by having objectives. So you guys know exactly what I'm talking about and how I'm going to kind of get to the slides. So I'm going to have with a little bit of introduction. And then after that, we're going to get to the types of shock. And there are very, very different varieties of like how you want to categorize shocks. And I think the best way to categorize it is how I'm going to present it to you, just because I'm biased to my personal opinion and personal learning. But I really appreciate how my residency training taught me to how approach shock from that sense. And then we're going to talk a little bit of medicine, because of course, so the pathophysiology of it and the medicine behind shocks itself. And then after that, it's all about the early identification of it, and that is the signs and symptoms of it. And then I'll give you a little bit of the diagnostic tools that we do in the emergency department and some of the diagnostic tools that you can apply. I even learned a new thing that I didn't even know it existed, and it was so cool. So I added it to the slides this time, and I'm going to look forward to tell you guys about it. And then after that, we're going to talk about management strategies and how we can strategize managing all those different types of shocks. And then we'll get to some case studies. I'm not going to make it complicated. We'll talk about some simple case studies, but they're very, very similar to what we see on a daily basis. And then after that, we're going to take a moment to talk about the most important teaching moments that we have. And then after that, some cool epidemiology and biostatistics. That's the boring part. So that's why I left it at the very, very, very end. And it's only one slide. I'm not going to talk about epidemiology and biostatistics forever. And then after that, we'll conclude our presentation. All right. So the definition. The word shock itself sounds very weird because it's like, oh, like, are we talking about vital signs? Are we talking about perfusion? What are we actually talking about? So I did like the definition that is uploaded by the American College of Emergency Physicians. And that definition is an abnormality of the circulatory system that results in an inadequate organ perfusion and tissue oxygenation. So the definition itself is like, if you can think about it, the circulatory system part of it, that's your vital signs. And then the inadequate organ perfusion and tissue oxygenation. So you care about your ventilation section of it, and then you care about the perfusion section of it, and that is the fluid resuscitation part of it. So that's kind of why the definition is really broad, but at the same time is very specific to the definition of shock itself. Now, the definition guides the trauma team in the diagnosis and the treatment. So diagnosing trauma relies on the synthesis of clinical findings and lab tests. So it's all about the clinical pictures. What kind of a clinical picture that you have and how you can approach that clinical picture in a trauma way. Because every shock that we have, we should treat it as a trauma. A lot of the times we get those elderly patients that they present as like, oh, they're too weak to function, but their blood pressure is a little bit soft, or that's kind of how it presents. And then it presents as like, oh yeah, it's like any other patient, but it's not really. It should be treated like a trauma, and it should have that early identification of a shock so we can actually reduce the morbidity and the mortality of these patients. All right, so how can we look at shock from an impact point of view. How does it impact our population and how does it impact our patients? So the management responsibility begins with, that's my point, early recognition of the presence of shock. So from an ambulance perspective, you guys are the first on scene. You guys are the ones who are actually going to see the entire environment of that patient, and then you are going to have that in your head right away. It's a snap. It's like, okay, I know that this patient is on their way to shock, or maybe they are already in shock. You early identifying that, you telling me when you give me the report that this is an early presentation of shock, you are literally part of saving their lives. Now, initiate the treatment immediately, because as soon as you find it, as soon as you think about it, as soon as it's in your head, you are going to identify it and then probably think about the causes. And we're going to cover all the causes with you guys. Now, the patient's response to initial treatment coupled with clinical findings usually provide sufficient information to determine the cause of the shock. So don't let the cause of the shock disturb your thought process, because your thought process, including the vital signs and the clinical findings, and eventually the lab test from our side, will give you the official presentation of shock. Now, the types. When it comes to the types of shock and how I want to identify it, it's kind of weird, because a lot of people think about it as like, oh, you're losing blood or you're not losing blood. If you're losing blood, that's kind of like what hypovolemic shock is. And if you're not losing blood is everything else. I like that approach a lot because it's kind of solid, right? So I think about it as hemorrhagic, which is basically hypovolemic, right? So you're losing some sort of a volume. It doesn't necessarily have to be blood, but blood is definitely on top of your thought process. And then non-hemorrhagic, which is basically everything else. And then in the non-hemorrhagic category, then I like to kind of differentiate them. So I have the cardiogenic part, and that is basically your heart and your lungs and how they, when they crash, everything crashes around them from your organ systems. And then after that, you have the distributive. That's kind of weird because the word distributive, it doesn't give it like legitimate definition of it. I like to think about it as how the circulatory system is acting. So the distributive part, think about it as all your peripheral vessels, if you think. And then you will have the neurogenic approach, and then you will have the septic approach. So these are kind of the shock definitions. And then after that, you have the stuff that is a block, so or an obstructive shock. So in that little vessels and all those roads, some of those roads are blocked. So are they blocked at the heart level? Are they blocked at the lung level? Or are they blocked on the peripheral? Kind of think about it that way. So you have your cardiac tamponade. That's basically a fancy word for something that is blocking the heart from doing what it's supposed to be doing, which is basically the contractions, or the tension pneumothorax, and that is basically something that is blocking the lung from expanding. And then the pulmonary embolism, which is basically your fancy blood clot that is stopping the perfusion of the lung itself. As a result, you will have problems with oxygenation, and as a result, you will lead to acidosis and all kinds of things. And then the last one, that one that we sleep on and we don't actually pay attention to it, is the anaphylactic part of it. And we're going to approach anaphylaxis as well from a different perspective, so you can identify it early and able to have your intervention right away. Alrighty. So the first one, that is the most common one. That's the one that we see almost daily with every single patient. And the hypovolemic shock can happen from so many reasons. So the idea here is that the oxygen delivery itself is diminished. How? By a loss of circulatory volume, resulting in decreased preload. Okay? So the preload, it's kind of like it's a word that is like we use in medicine, but we don't really explain it. So how I look at it is anything that is before the heart. So all your volume that comes in your system before it reaches the heart, so it can be distributed throughout the rest of the system. That is basically what preload is. So when you have a loss of volume or a loss of circulatory volume, you will have decreased preload. So what happened when you don't have enough volume? What happened when you don't have enough of that in your system? You will have what we call a compensatory response. So your body will try to compensate. So they will do what we call a sympathetic nervous system, and that will basically leads to an increase in systemic vascular resistance and heart rate. So the heart will try to do something. I'm not having enough volume, so I'm just going to beat a lot. So you will have all those crazy patients with crazy amount of tachycardia, and sometimes they will even throw themselves in an AFib RVR. And as simple as you giving them liter of fluid in route, it will completely heal their AFib RVR, which is kind of wild. So like the heart is just trying to compensate to the fact that they're losing so much volume or so much blood by increasing their contractility. And at the same time, all your blood vessels are going to constrict. The constriction will help raise the blood pressure up. However, it will also destroy the perfusion because you don't have enough volume to perfuse, which is kind of crazy. But the body is trying to do what it's supposed to be doing without necessarily knowing the clinical picture of it. That's why our approach and our critical thinking skills is very, very important in that particular time of early identification of a hypovolemic shock. Now, most common causes are the hemorrhage, which is basically very, very common. We have an internal hemorrhage or external hemorrhage. You can see blood everywhere. And then the first thing that you do is tamponade on it or actually put pressure on it so you can stop the blood loss. And then the second one, which is the internal one, you don't know. You had somebody who was in a car accident, they have a little bit of bruise on their belly, nothing too crazy. Meanwhile, they had a major liver lack or had a major splenic lack, or they're really, really hypotensive to the point that we can't even put them in a CT scan and we need to rush them to the operation room. So the idea here is that have a very low suspicion to motor vehicle accidents and low suspicion for any type of trauma, even for kids. Like I will never forget that little kid that I got who was literally on a bike 2 days ago and then came in with belly pain and he completely ruptured his spleen. So it was kind of wild to me that I was like, oh my God, like as soon as we saw it, as soon as we identified, we did the diagnostic skills and he was out of our department in 20 minutes. It was the fastest transportation that we've ever had in our lives. Well, in Freeman ER lives, but it really matters. So like the early identification is very important. Now, you have also severe dehydration, all those elderly who are not hydrating well, and they are on a bunch of diuretics and a bunch of medicine that is actually contributing to their dehydration. So dehydration by itself is a major contributing factor to hypovolemic shock. We get elderly patients who are very, very, very sick because of simply dehydration, and that is that. Or they're just having diarrhea for 3-4 days and they feel weak. Why? Because of the diarrhea and how much fluid loss that they lose, whether it's from the vomiting or the diarrhea. Any GI loss is considered to be a hypovolemic shock until it's proven otherwise. So always have a low suspicion on that. And then any urinary tract or skin, again, the diuretics part of it, and that's where the urinary tract is where we're going. And then the skin, those are the people who go for marathons or people who are working outside in constructions and then they sweat a lot. So the diaphoresis or the perspiration part of it is also significant to the point that they can put themselves in shock. So always have those kind of ideas in your head. Now, the second type of shock, that is the cardiogenic shock. Now, we finished all the hypovolemic / hemorrhagic shock, so we lost all that fluid volume stuff. Now we're going to, each and every single organ, we're going to talk about and how that organ can contribute to the word shock or abnormal perfusion. So the cardiogenic part, I always look at it as a heart attack. Somebody got a heart attack and somebody mean that their heart is not doing what it's supposed to be doing, right? So the contractility of the heart, the lub dub that we usually listen to, it is either affected or some of the valves are not working the way it's supposed to be working, or the ventricles are not doing the contraction part of it. So they have what we call a myocardial infarction. So a heart attack or a myocardial infarction is actually the most common cause of a cardiogenic shock. I had a resident the other day that he was telling me, is like, oh, you know, I had a patient that we were doing CPR on, but we never consulted cardiology for. Why is that? Because not every patient that we do CPR on is having a heart attack. A lot of people that we're doing CPR on were doing CPR because of hemorrhagic shock or because of volemic shock or because of any other reasons. It does not necessarily need to be the heart. So that particular association, it was kind of weird because it's like, oh, so we can do CPR on patients that do not have heart attacks. Yes, that's kind of the idea. So suspect a blunt cardiac injury when the mechanism of injury to the thorax involves a rapid deceleration. And that's the part of the mechanism of a motor vehicle accident. So a lot of the times, like when you guys tell us about the mechanism of the car accident, it's like, oh, you know, this is what happened, or the car was flipped that way, or the miles. All these little details that you guys provide us are very, very, very important because it draws the picture in your head, it draws the picture in our head, and then with that particular picture, we can tell how bad the accident was, right? Were they wearing seatbelts? Where the airbags were deployed, where the windshield completely destroyed, where the patient is actually distraught out of the car, or what is the clinical picture that you guys saw, and how that clinical picture can be actually presented to us. And that's what's important. And then the left ventricular fails to deliver the oxygenated blood. So you have that blood in your left ventricle, but it's not actually contracting and delivering that oxygenated blood to the peripheral tissues due to variances in contractility, preload, afterload, and right ventricular function. So you have a pre-oxygenated blood, and that is your preload, and then it gets to the heart, so the heart can function and contract all that oxygenated blood after it reaches the lungs to your peripherals. But what happens was, when you have a myocardial infarction, the heart is not doing that. So you're not allowing circulatory oxygenated blood to reach the peripherals. So what happens when that happens? You drop. You literally get yourself in a cardiogenic shock. And then that's when we need to identify that the heart is not doing what it's supposed to be doing. So we need to intervene, whether the intervention has to go through the cath lab, or whether the intervention has to start with you guys by giving enough fluids and enough preload that will allow the perfusion of the heart. That's the idea. And then next, we are going to talk about the lungs portion of it. I hope so. Okay, so the neurogenic shock. So the neurogenic shock portion is the portion that is responsible for the brain and the spinal cord. So the word neurogenic shock itself was throwing me off a lot, because I get a lot of people with like, oh, their blood pressure is like a little bit okay, but they're not having enough reflexes, or they have legit focal neurological deficits. And then the definition of neurogenic shock versus spinal shock, and what is really the differences between those two definitions. It always throw me off. So we'll approach it one by one. Cervical and upper thoracic spinal cord injuries can actually produce hypotension due to the loss of the sympathetic tone. So you can think about it. The upper cervical chains, that's part of your spinal cord that is responsible for the sympathetic system. And the sympathetic system causes vasoconstriction. So when you have a patient that had a spinal shock, they will drop their blood pressure. No matter how much fluids you want to give them in the field, it's not really going to make a difference. Why? Because their vessels are not contracting. Their vessels are not doing what they're supposed to be doing, because they got a whole spinal shock. And then it takes them a couple of hours until they go through that shock to go back to the normal rhythm and to go back to the normal senses of the nerves, and then the sympathetic part will come back again. But that will take a couple of hours. So those hours, you are not going to be able to witness that. You're just going to see the hypotension. You're going to put fluids in it, but it's not going to make a difference. So just identify the fact that fluids are good, but not all the time. Now, this compounds the physiologic effect of hypovolemia. And then the hypovolemia compounds the physiologic effect of sympathetic denervation, and that's the part that I was talking about. And then it equals the hypotension without the tachycardia, without the cutaneous vasoconstriction. So remember when we talked about the tachycardia and how the tachycardia is a compensatory mechanism to the hypotension? So you have hypotension, elevated heart rate or tachycardia, you give the fluid, the blood pressure gets better, the heart rate gets better. Now you have an idea of like, oh, I'm dealing with hypovolemia. I'm dealing with like hemorrhagic / hypovolemia. But if I'm giving the fluids and the blood pressure is not getting better, the heart rate is not getting better, maybe they did traumatize themselves. Do they need to be in a car accident? Not necessarily. Do they need to have some sort of an actual trauma that maybe they just simply fell off the bed? Maybe. That's the idea of a spinal shock. So any sort of a trauma / an impact to their brain or their spinal cord can cause that neurogenic shock. So kind of have that in your head. Now, the famous one, sepsis. I think Dr. Iraqi was one of the people that is responsible for sepsis this year for you guys. So he went through the entire sepsis bundle. So I'm not going to go through the whole sepsis bundle, but what I'm going to do is I'm going to approach sepsis from a very, very simple physiologic approach. So you got your bacteria, you got your white blood cells, and then the bacteria and the white blood cells will have the biggest war, and then that war will result in what we call cytokines. So cytokines is basically part of our immune system, and those interleukins and immunoglobulins and all those fancy words that we use in medicine that basically describe that immune system. But that immune system is going to destroy your vessels. It's going to leak, and that leaky vessels will cause drop of the blood pressure. That's why they're very, very, very hypotensive. No matter how much fluids that we push, it's not really going to make a difference either. It will make a difference to a certain point, and that's where the sepsis approach is that we need to hydrate them just enough, and then the medicine will come in after. So you will have areas in your body that are affected. So you will have brain damage or anoxic brain injury. You will have part of your lungs that are not perfused well. As a result, they will need ventilation or even literally being intubated and put in a machine. And then their heart is not doing what it's supposed to be doing. And as a result, you will have the elevated troponins and STEMI and all those conditions. And then you'll get to your liver, and liver shock. Oh boy. Liver shock can be a whole different approach just because you're not getting enough blood. And then as a result, they will need eventually liver transplantation and things that are way beyond our scope because we were not able to identify sepsis earlier. Never let the patients go to that point. And then of course, with kidney failure, they can get to dialysis and how we can handle their chronic kidney disease in general. So now, how can we talk about cardiac tamponade? And how is that very, very, very important in your guys' perspective? Because cardiac tamponade is one of those conditions that you can see in the field right there and then, and you will have to have your intervention right on the field. So whether you are going to listen to their heart sounds, and they're very muffled, and they're very kind of like not clear, or you're just going to use your ultrasound. I like the ultrasound a lot, and I know with you guys, you don't have ultrasound on board. However, some of the medical students that I saw, they actually carry this little butterfly ultrasound thing, and it's great because it's like literally like it's in their pocket, and they pull it up, and then boom, right away, and then you get the answer. So it's kind of nice to know that I have portable butterfly ultrasounds that, if possible, a couple of butterfly ultrasound can be managed with EMS people, so we can have it. But since the medical students are already doing it, maybe we can also have a couple on the board. Something to think about in the future. However, you take that ultrasound, you put it on the heart, and then you can identify it, right? So this is the clinical picture, the classic picture. You got your right ventricle, that's the RV, the right ventricle. And then the LV is the left ventricle. So the probe or the ultrasound probe, it's at the north portion of the image. And then when you look down, the first thing that you're looking through your ultrasound is actually the front of the heart. And the front of the heart, the biggest portion of it is your right ventricle. So the right ventricle is the first portion that you see, and then the left ventricle. And then on top of it, you can understand that this is the left atrium, and this is kind of where the portion of the aorta is. And then this is the part. This is the part that we actually look and identify. This is where the effusion is. This is where either heart or fluids or cardiac, whatever effusion, something is there that is stopping the heart to completely contract and fill. How do we fix this? Immediately, you put a needle in it and you get all that blood out. Exactly. And this is the best approach. This is something that you see, you know that this patient got into a car accident, they are in bad shape, I can't listen to their heart, I can barely hear the lungs. You know you're dealing with cardiac tamponade. You know you have to do something right there on the field. And then the second one, which is the lungs portion of it. So you get the hyperresonance sound, or the hyperresonance to percussion, and completely decreased breath sounds, or sometimes are even absent. So you put that stethoscope on, and then it's like, oh damn, I'm not listening. I can't even hear a lung sound. The next thing that you do to confirm, what I like, again, is the ultrasound approach, because I can easily put the ultrasound on, and then when I put the ultrasound on, you can look at it from the north portion. You can see the muscles, and then the first thick line that you see, that's basically your ribs and how they're meeting with the lungs. So in a normal, if you just take your ultrasound and you put it on yourself and you look at the normal, you will see this kind of phase, and kind of what I like is like the waves. And those waves are great because that's how the lungs are usually expanding. However, when we get pneumothorax, that's when we have that absence of waves. So it's just kind of barcode sign. And that's kind of what we have, is like, oh, there's nothing moving. That's when you know that there's no enough expansion. Why? Because the lungs are not touching the ribs anymore, because there is air. That's what we call pneumothorax. So one of the lungs blebs either ruptured, or because of the trauma, the ribs got broken and then they punctured the lung. Either way, there is air in the intrapleural space. How do we get that air out? You put that needle in, and then you get that air out right away. It is a very, very emergent intervention that these are like the bread and butter of emergency medicine, especially when it comes to heart and lungs. Small little needles, well, they're not really small, but 16 gauge needles, give or take, they can actually take care of that particular emergent intervention. And then eventually, once they get to our emergency department, we handle it by doing a full-on pericardiocentesis, or we handle it by doing a full-on chest tubes. That's the idea. All right. Now, the next section will be the anaphylactic shock. So with anaphylaxis, it threw me off. Like, I get those people who's like, oh, I got to Vietnamese place and I had pho, and then all of a sudden I can't breathe, or I was eating this random thing that I've never been eating before, and now I feel like my face is weird and tingly and numbness. It's not always about the rash, but when anaphylaxis can lead to shock, that's when we need to be very, very, very alert and aware, right? So the diagnosis of anaphylaxis itself is always clinical. No matter what they tell you, it's clinical. So consider it when involvement of any 2 or more body systems is observed. So if I'm just having shortness of breath, but that's it, is that really a shock? Not necessarily, because you have to have involvement of multiple systems to call it a shock. So the idea here is that if I got shortness of breath and now my face is tingly and I have a rash and I don't feel too well, you have multiple systems. I have lungs, I have skin, I have vessels, and now I have neurological symptoms. That's anaphylactic shock. That's kind of the idea. So it's the collection of symptoms that give you the clinical finding. A complaint of a lump in the throat or hoarseness, it kind of heralds life-threatening laryngeal edema in a patient with symptoms of anaphylaxis. And that's why airway protection is absolute key. You guys put them on another breather. You guys do whatever it needs to be done when it comes to their oxygenation. We want them to be pre-oxygenated prior to arrival. I remember I had a patient with anaphylactic shock that you guys did all the pre-oxygenation. As soon as they arrived, I did the intubation right away without worrying about pre-oxygenation, because they were on another breather the entire time in the road, which is very effective, and that's what we want. So I don't have to worry about pre-oxygenating them or them crashing on me while I'm in the middle of intubation. And that's the best part. Now, the faster the onset of symptoms, the more severe the reaction is. It can happen within minutes. It can even happen before you guys arrive. And we're going to talk about your emergent intervention as well. Now, 1/2 of the anaphylactic fatalities actually occur within the first hour. So if we don't do early identification, if we don't intervene, they die within the first hour. Just pretty crazy, just kind of given the fact that anaphylactic shocks are actual serious conditions. Now, when it comes to the pathophysiology of hemorrhagic shock, there was old medicine and there is new medicine. I used to be on the old medicine section, and then residency taught me how to evolve myself into modern medicine, or how to look at it from a modern perspective. And I really like it a lot. So hypothermia, coagulopathy, and acidosis. This is kind of like your triad of old medicine, right? I care about, putting them on warm blankets, and then maybe transfusing whatever blood I have, and then not really care about so much about acidosis, but they will have some sort of like derangements. Now, that definition changed. Rather than looking at it from a 3 perspective, we can look at it from 4 perspectives. So we can actually broaden it and at the same time categorize it. And that's kind of how they decrease morbidity and mortality when they identify the hemorrhagic shock portion of it. So the iatrogenic part, that's your part. That's the part that you need to identify the fact that they were losing blood. So you're stopping the bleeding, you're giving them fluids, and you're actually keeping them warm. That's your portion of things. Hemodynamics, you're looking at the vitals, you're early identifying the fact that they're in shock, and then you're doing whatever necessary that needs to be done, whether getting IVs, because in a patient with hemorrhagic shock, we need 2 large bore IVs. And then after that, you look at the hematologic portion of it, and that's my portion. That's the massive transfusion protocol that I start immediately as soon as they arrive, by giving them enough blood product and also giving them enough platelets or fresh frozen plasma, whatever I need. And then after that, I do the metabolic derangements. And with all those transfusions that I'm giving, they're either going to be super diluted, or they're going to throw themselves in metabolic acidosis condition that actually requires me to fix their underlying metabolic condition so I can get them ready to the ICU. So this particular approach really did improve medicine when it comes to hemorrhagic shock and when it comes to sepsis, literally. Now, the cardiogenic shock pathophysiology of it. We talked about the preload portion, so I kind of wanted to include them all together in what we call stroke volume. So how I look at what we call cardiac output. So cardiac output is like a broad spectrum of a definition. So we define it into two categories. We have stroke volume and we have heart rate. So if you manage heart rate and manage stroke volume, you're going to have good cardiac output, and as a result, you will have a good perfusion, and as a result, you will actually treat the shock. That's how we look at it. And if you know how to identify the fact that your patient is losing blood or volume in the preload section, then you will give them that. If you know that your patient is having a heart attack in the myocardial contractility section, then you will need to get a cardiologist as soon as possible, or take them to a hospital that is level 1, what do you call it? A cath lab, like a STEMI. And then after that, the afterload portion of it, that's the portion that they're not having enough constrictions. Maybe they need particular types of medicines that are pressors and whatnot to kind of help the perfusion portion of it. So stroke volume is basically preload, myocardial contractility, and afterload. Together is what we call stroke volume. So you get that stroke volume, and then you multiply by the heart rate, and then you will know how much output is your heart is actually giving to the body. All right? Now, the pathophysiology of it is the profound depression of myocardial contractility leads to catastrophic decrease in cardiac output and blood pressure, perpetuating further coronary ischemia and contractility impairment. The activation of sympathetic system may lead to improved coronary perfusion at the cost of increased afterload. I love that portion because that's the portion that throws doctors off. That's the portion that is like, okay, I don't even know what I'm doing, because they are actually not understanding the fact that there is a cost when you increase the afterload. You can give them enough medicine to get their blood pressure up, and yay, the numbers are looking great. However, they're not perfusing their organs. They're not oxygenating properly. And as a result, you're making it worse. And that's the portion that a lot of people actually miss. Now, tachycardia, it does increase the myocardial oxygen demand. So think about it. If the heart is going to compensate and is going to go up and to shoot themselves an AFib RVR, the heart itself is not getting the chance to perfuse itself. So it's like a muscle, but I'm not able to catch up. And then as a result, I'm going to die from not catching up. It's wild. And that subsequently will actually worsens the myocardial ischemia portion of it. And you will get yourself into a heart transplant later on because you're not actually saving the heart itself and the root cause of the problem. Now, how we approach the pathophysiology of neurogenic shock is basically the primary injury is the direct damage to the axons and the neural membranes in the anteromediolateral nucleus. It's a fancy word that is basically the portion of it is part of your spinal canal. And then the lateral gray matter and the anterior roots. All these are basically the anatomy of the spinal cord that leads to disruption of sympathetic tone. And then secondary spinal cord injury occurs hours to days after the initial insult. Secondary injury results from the vascular insult. So you can actually have a hypovolemic hemorrhagic shock that leads to not enough blood vessels through the vertebral artery. And as a result, your spinal cord will be thirsty. And then your spinal cord will not going to be doing what it's supposed to be doing, and then it will crash. So you can have a hemorrhagic shock that leads to a spinal shock. It exists. And then you will have electrolyte shift, because if you are in acidosis and you have plenty of metabolic derangement, the cells of the nerves itself are not going to survive but by doing the osmosis. And as a result, they will shrink and they will lead themselves into apoptosis. And then when that happens, the cells are not able to regenerate themselves. Pretty bad. And then the edema will lead to progressive central hemorrhagic necrosis of the gray matter at the injury site. Now, the organisms of the septic shock can cause direct injury that can provoke hemodynamic collapse. The host immune response, those are the cytokines that we talked about, can result in an injury and can also result in hemodynamic collapse. With the development of hypotension, tissue oxygenation demand is not met, and that's why it can lead to metabolic derangements. A shift from aerobic to anaerobic respiration with ensuring lactic acidosis actually occur. So this is the part that we are unfortunately unable to deal with, because lactic acidosis is part of the sepsis criteria and how it can happen. Your cells are getting oxygen, they are doing great, and the mitochondria is doing what it's supposed to be doing. However, when you are in shock, your mitochondria is not doing that portion of the oxygenation. As a result, they will need to switch to what we call anaerobic metabolism. Anaerobic metabolism will lead to lactic acid. And the conditions like lactic acidosis, when we see patients with lactic acidosis of 14 and 10, that's when we know it's bad. That's when we know that this septic shock is so bad to the point that every single cell in your body is doing anaerobic. If they're doing anaerobic metabolism and they're not getting enough oxygen and they're not getting enough perfusion, the chances of you dying is really high now. Like, it's bad. Like, no matter how much fluids that we give, no matter how much pressors that we do, it's too late. So lactic acidosis is a great indication of how bad their condition is and how severe their septic shock is. Now, for the obstructive portion of it, we talked about it. It occurs as a result of the decrease in the venous return or the cardiac compliance due to increased left ventricular outflow obstruction or marked decrease in preload. So that's the obstruction portion of it. It can be classified according to the location in the vascular system in relation to the heart. And then common to all these obstructive states is often rapid, massive drop in cardiac output and blood pressure. Now, the anaphylaxis portion of it arises from the activation of mast cells and basophils through the mechanism involving the cross-linking of IgE and aggregation of high-affinity receptors response to the IgE. That's the portion of the anaphylaxis. And that's a little bit of the medicine of it, but IgE is basically a portion of the immune system that is responsible for the mast cell activation, and as a result, you will get yourself into the anaphylaxis portion of things. And then there is IgG and IgA and all other stuff that are not actually related to this lecture. Now, the quick release of performed mediators, including histamine, tryptase, and proteoglycans upon the activation. And they stimulate vasodilation, so they drop their blood pressure. They increase vascular permeability, so they will have the cutaneous rashes, they will have the perspiration, all these things. And then they will increase their heart rate, they will have cardiac contraction, and also glandular secretion. Now, the signs and symptoms of anaphylactic shock. I like those tables. I actually got them straight up from our book, Tintinelli. That's the book that we use for our emergency medicine training. And what they did in the book is they looked at it in the clinical criteria of anaphylaxis itself, and then they saw the urticaria, generalized itching or flushing, and then the edema of the lips. So you can have edema of the lips, the tongue, the uvula, and you can even have it over minutes to hours, and then associated with at least one of the following: either respiratory distress or hypotension, or associated organ dysfunction like hypotonia, syncope, or incontinence. Ooh, the syncope portion, because they can pass out and then we don't actually know that they're passing out from anaphylactic shock, which is kind of wild, but it happens. And then 2 or more signs or symptoms that occur minutes to hours after the allergen exposure itself. So you can have mucosal involvement, you can have respiratory compromise, you can have hypotension, and then persistent GI cramps and vomiting, which is kind of crazy, but it happens. Like, you know, they can get anaphylactic shock and then they start puking all over the place. And like, you can think of the puking is like, oh, you're just having like a GI bug. But it's not really a GI bug, it's actually anaphylaxis. So like, keep that in your head. And then consider the anaphylaxis when patients are exposed to a known allergen and develop hypertension. Because they give you the answer. Oh, you know, I had this, and then I am allergic to it, and I didn't know I had it, and now it's in my food. This is very important information for us to know. And then the clinical manifestation of anaphylaxis, I liked how they also categorize it. So in the neurologic section, they said headaches or seizures. They can actually get seizures. GI, nausea, emesis, cramps, diarrhea. And then the skin, you can have the urticaria, the flushing, the pruritus portion, the itchiness portion of it. And then the cardiovascular, you get the drop in the blood pressure. They can get some chest pains as well. And you can think about the chest pain because they're not getting enough blood flow to their heart, and that's why they get the chest pain, if you think about it. And then the respiratory portion, you'll have the shortness of breath, the wheezing. That's very, very common. And you guys do your DONF treatments very nicely, actually, on those patients with wheezing and shortness of breath. It does not have to be COPD. They can be wheezing from anaphylaxis, still wheezing. And then you get the laryngeal edema or the stridor, and sometimes they can just get rhinitis, or how do you call it? Rhinitis or allergic rhinitis. ENT portion, so they will have the throat fullness, the tongue swelling, or the uvular swelling. So as soon as you see the swelling, you know it's very emergent, and they know that they need that tube. Whether that tube needs to be done in the field or in the hospital, that is your guys' decision in terms of recognizing how far are you and what are the next steps. And if the tube is not going well because they're very, very swollen, use your iGel. Use whatever temporary measurements that needs to be done so you can get enough oxygenation in their system prior to them arriving. Now, the treatment, and that's the part that I like because it's easy and it's available and we have it everywhere, and even including the patients. Sometimes they have EpiPens that are expired. They're like, hey doc, can I still use this? I don't know how to answer that question, but it still happens. It's just kind of crazy. So the first line of therapy is airway protection and oxygenation, and then decontamination. Ooh, that decontamination section, I forget about it because they get exposed to all kind of things, and then we don't undress them or we don't give them clean gowns because it's important. The decontamination section of it is very important. Sometimes it's even if it's legit decontamination, you have to like give them showers and stuff before they get into the ER as well. So that's kind of part of it. Identifying the caustic agent and terminating the exposure. And then you got your epinephrine, and that's the intramuscular choice. You can repeat every 5 to 10 minutes depending on the response. So if they respond, great. If they respond and then they crash again, guess what? You need another EpiPen. And that's kind of how it goes. And then the second line of treatment, that's what we give in the emergency department. We love this. We do steroids, we do antihistaminics, we do Duanibs, we do all the things. Because you got to stop that immune response, which is the IgE linking mast cells that we talked about. Now, the diagnostic tools. The diagnostic tools are so simple, but at the same time, a lot of the time, we actually miss it because we don't think about it too much. So, the physical examination is focused on diagnosing immediately life-threatening injuries and assessing the ABCDE, airway, breathing, circulation, disability, and exposure. So, physical exam is important. Do not miss physical exams. Baseline observations to assess the patient's response to therapy and repeated measurements of vital signs are crucial. Urinary output is very important because if you're peeing, you're telling me that you're hydrated enough. And I can actually function well knowing that your kidneys are doing what it's supposed to be doing. And then the last one is the level of consciousness, because a lot of the time we miss that portion. And that portion can tell us a lot of the things that we need to know, especially with GCS scale. Now, the ultrasound, that's my favorite portion. I can do a fast, so I can get the ultrasound on your belly and kind of scan particular portion of the belly that can tell me if you're bleeding blood inside, if you're having an internal hemorrhagic shock that needs immediate intervention. And then I get my quick EKG and I get my cardiac enzyme panels so I can look at your heart rhythm, how it looks, and see if your heart is under a lot of stress to the point that the troponins or the cardiac enzyme panel are actually going to shoot up. And then I'll get my CTs, those are my favorite portion, or I'll get my x-rays. So I like x-rays because they're quick, easy, effective, and at the same time, it can tell me a lot of things. I can get a quick chest x-ray and then see that your lung is not inflated well, and then that will be my indication for straight up chest tube. You don't have to have the abnormal vital signs for me to see the pneumothorax. Or I can get the chest x-ray and then your lung sounds are clear, but they're not really clear. But then when you get the chest x-ray and you see that little Nemo, you'll be like, oh, okay, it's there. So I was right when it came to listening to the lungs, because it doesn't have to be absent. You can have a little bit of breath sounds, but they're not the clearest. And that's kind of your kind of detail to know. And then head and cervical CT, we got to scan their head. We got to make sure they're not bleeding. And we're going to make sure that we're not dealing with a fracture of the neck. And then we'll get the basic blood work, including type and screen. We miss that all the time. And then I'll get my basic electrolytes. And then, of course, the lactic acid if I'm concerned for sepsis. Now, remember when I started the presentation by telling you about something that I learned in my residency, especially the last year, which is very cool. So, shock index. I had no idea what that is. And I learned about it, and it's great. So you take your heart rate, you have your vitals, right? You take your heart rate, and then you take your systolic blood pressure, and then you divide them. And then you will get like 0.6 or 0.5 or 0.8 or point, what does that mean, right? So this is basically, it will raise your alarms, right? And you will have like that red flag in your head. And that's the point of me trying to do. So if you are in the field, and you get your basic vitals, and you get your heart rate and your systolic blood pressure, pull up that calculator, put those numbers in, and then see what you get. If you get less than 0.6, the chances of you having shock is there, but it's not that bad, which is very reassuring. So the chances of them needing blood products, maybe 1 unit in the future, not a whole lot. What is the chances of their mortality rate? It's still there. 10% is still there. It's still high. You are being called. You're in the field. There's definitely something wrong. However, it's not that bad. Now, when you plug those numbers in, and then you get between 0.6 and almost to 1, ooh, now you are supposed to be concerned. Now it will kind of like give you those tingling red flags in your head. They'll be like, oh, damn, something is wrong. You get that moderate shock, and then it's more than 1, or it's 1 to 1.4. I'll be like, oh, yeah, I'm dealing with shock. I know it's shock. You come to my emergency department, you give me the report, and then you throw my shock index at the end. I might lose it because it's totally happening. And this is the chances of them increasing the mortality rate. It can get to 39.8%. That's crazy. And they did this particular research on more than 20,000 patients, and they realized it was very effective tool. Shock index. Heart rate divided by systolic blood pressure. Systolic. Why systolic and not diastolic? Because we talked about it. The perfusion section of it. So you get the heart rate, you get the systolic. So if you think about it, the 120 over 80, and then I get a heart rate of 80, so you do 80 over 120, I'm less than 0.6, I'm good. But you get that heart rate of 140, whether it's AFib or not, it doesn't matter, but it's 140, and your blood pressure is 70, ooh, now we're talking. Exactly, yeah. What number did you get? 1.75. So 1.75, that's crazy. That's like, okay, you're like literally a severe shock. And then the chances of you needing blood products, that's wild. 9.9 units and 21.4 units. That's like beyond massive transfusion protocol. At this point, that's where kind of like, okay, something is really, really wrong. So if you guys want to take anything from the slides of today, it's shock index, because I learned that and it helped me a lot, because I get those old patients that are like, they do look sick to me, but like their vitals are not right and I don't know what's going on. And then I use the shock index and I was like, oh, wow, they're in shock. And now I can think about what kind of shock that they have, and then I figure it out. So now I have a reason to how to treat them. So it gives me the red flags. It gives me the tingling in my head. And it's like, now I remember it very, very well. Shock index. Keep it in your head. That's the one thing that I want you to learn today. And I would really appreciate it if you apply it in the field, because it will help you. And it's so simple. It's just the vital signs. That's what they do. All right, management strategies. You establish your airway, and then you do the intratracheal intubation, best airway control. And then controlling the work of breathing is very important. That's what we do in the ICU. We put them on the machines, and the machines do all the magic for us. Of course, after we put all the settings. And then we allow adequate oxygenation, and we improve the hypercapnia of it. And then the goal is to decrease the work of breathing so we can improve survival. How? We're giving your lungs a break. We're giving your heart a break. We're giving your organs a break to heal, to do what they're supposed to be doing later on. And then we are taking control. Optimizing the circulation begins with IV access. Your IV access in the field is very important. I know a lot of people are heart sick, and a lot of people, they don't have IVs. And I get a lot of patients without an IV, which is wild. But it happens, and I get it. You guys have your circumstances. But always try. Always try to get an IV on that patient, because you don't know what will happen. We will need that large IV. And then if peripheral access cannot be obtained, then we can come in, we can do the IO. You guys do the IO too, especially when we are running codes and doing CPRs and all the things. I see 2 IOs, and I was like, yay, I got my access. And then if circumstances prevent the use of peripheral veins, then I can do my central lines. I can drop those central lines in places that have large caliber. And then the need for central access should be individually determined. Not everybody needs a central line, because central line actually have higher risk of infections and higher risk of vascular compromise. Now, I will assess the patient's response to fluid resuscitation. I will identify early identification, evidence of end organ perfusion and tissue oxygenation, and then I will observe the patient's response during fluid administration. You can do that too in the field while they are en route. You're seeing the fluids running in, you're seeing the blood pressures improving, and then best further therapeutic and diagnostic decisions on their response. Now, the pressors section of it, that's the section that we come in as medicine in the ICU, so we can give them the norepinephrine, the epinephrine, the dopamine, all the things. So we can actually help their inadequate response to volume resuscitation. They should be reserved for cases of persistent hypotension and tissue hypoperfusion after volume resuscitation has failed. You give them 2 liters, you give them 3 liters, you give them whatever 30 cc per kg rule. And then once you get to that rule and they're not any more longer responding, you need to go to the big guns. Push doses of pressos are also good. I believe that you guys do neo pushes and you do epi pushes sometimes too, depending on how bad the situation is. It's nice that you have that tool. Now, I finished my presentation. The case studies portion of it, that's kind of the portion that I kind of wanted to save if I have time. And I think I have time. Can I do the case studies? Yeah? Okay. We'll go through the case studies quickly with you guys. I might not get responses, but that's fine. We'll kind of walk you through it. We have one response here. That's great. All right. So you respond to a report of a 20-year-old female, okay, who was a restrained driver of a small car that is struck on the driver's side. So you can think about the mechanism. She is the driver's side, and she got struck by a car, by a pickup truck. Okay. Now there is significant intrusion on the driver's side. Okay. Your patient is alert times 3. She's anxious. She's complaining about pain in the left side. My left side hurts. There's no obvious bleeding. She has good pulses, radial pulses, and her skin is cool and dry. All right. You extricate the patient onto a backboard. You do your cervical thing. Her first set of vital signs are blood pressure 136/86. That's great. Heart rate 132. Not so much. Respiratory rate is 20. Kind of okay, but she's still a bit tacky. Now, is this patient in shock? Question mark. What will be? Yes or no? Early? Ooh, I like it. She might be actually in shock. While her blood pressure looks normal, the mechanism of injury is very significant, and her elevated heart rate and cool skin are concerning. If we put her numbers in the shock index, she's going to be up. And that's what, over the next few minutes, the patient becomes slightly restless and complains that she feels short of breath. Her repeat vital signs, 132/90, but her heart rate is not getting any better. It's 144, and respiratory rate is 22. Her skin is cool, and now it's damp. What do you think is happening? Exactly. She's getting shocky. Although she's still not hypotensive, this patient is clearly progressing down the shock pathway. She may be bleeding from a lacerated spleen, a fractured pelvis, or any other injuries, leading to shock due to low blood volume. You don't have to have the crazy hypotension that is like, oh, she's shocked. You can have regular blood pressure the entire time, but other things will tell you, oh, my chest hurt. Oh, I can't breathe. Or, oh, I'm cool. I'm damp. There's a lot of things that kind of give you that clinical picture. And then the mechanism of injury. Early recognition and treatment can be life-saving. In addition to a backboard, C-collar, and rapid extrication, she needs a pelvic wrap. Always put a pelvic wrap on her. A blanket to conserve the warmth, because we talked about hypothermia. Oxygen, ALS treatment with IV fluids, possible airway management, and rapid transport to a trauma center. Good job, you guys. All right, one more case. Got one more case. You're called to a nursing home. Of course you're called to a nursing home because, duh, all our patients are being called from a nursing home to evaluate an 80-year-old male with a decreased alertness and orientation. Now, the staff tells you that this patient, who is normally alert to times 3, I don't know how to believe that, but has been increasingly confused over the past 24 hours. And today, he would not wake up for breakfast. Ooh, that's a red flag. The patient has a history of hypertension, stroke, and UTIs. So you got all the chronic medical problems. You find the patient laying in bed. He opens his eyes when you touch him, but does not really speak and doesn't really follow commands. You get some vital signs. Ooh, that blood pressure, 88/54. Heart rate, 148. And respiratory rate is 26. He's going to pull up the shock index calculator, and we're going to throw it in there, and we're going to get a number. My heart can't take it. His skin is flushed and hot to touch. What is the cause of the patient's shock? If you want to throw it out there, what would you say? Septic, I like it. I like it. Based on the previous history, he may have a UTI. Untreated UTI bacteria can invade into the bloodstream, produce toxins, damage cells throughout the body, causing leaky vessels, all the things that we talked about. And then boom, leading to the ability to loss of ability to constrict. And then as a result, they would have the loss of vascular resistance that leads to the drop in the blood pressure. So now you know. Now you see the numbers, you'll be like, yeah, I know what that is. Fever often accompanies septic shock, especially in the beginning phase. However, as the body begins to break down, temperature often falls. So don't get fooled. Patients who are afebrile can actually present with septic shock. You don't really need a fever anymore. Some septic patients can actually present with hypothermia. It even got to the point that they're hypothermic now. And then septic shock is as much of an emergency as hypovolemic shock. Patients need prompt transportation to a facility that provides them with IV fluids, pressors, antibiotics, and definitely an ICU so we can manage their condition. Now, this is the epidemiology portion of it. I left it at the very, very end, just some numbers. The population-wide incidence of shock is actually 76 per 100,000 person year and is more common in men, older patients, rural settings, and those with a lower socioeconomic condition or status. Distributive shock is actually the most common type of shock, followed by hypovolemic and cardiogenic shock. And then obstructive shock is relatively less common. We don't put needles on hearts and lungs every day. The most common type of distributive shock is actually septic shock and has a mortality rate between 40 and 50%, which is quite amazing for the numbers that we can get on septic people. And that is it. My conclusion is basically early, accurate identification of the patient's stage and type of shock is essential in managing patient's condition. We talked about it. Sound clinical reasoning skills, a thorough assessment, and careful but expedite interpretation of diagnostic findings are necessary to provide effective treatment for the patient who is in shock. And those are my references. I appreciate you guys listening to us. Thank you so much.
Just get 21 units of blood.
Exactly.
Yeah,
2 years of blood. Any questions? Yeah, what?
The whole blood bank, right?
The whole blood bank. Yeah, they're all waiting on us. Anyone asking any questions online, or we're good?
No questions. A lot of thank yous.
All right, appreciate it.
Yeah, appreciate it. Thank you. So I missed it at the beginning. I was probably outside. Was